Hi, this is Dr. Aida Wen. I'm a geriatrician and an associate professor at the John A. Burns School of Medicine. This topic is about recognizing and addressing depression in the nursing home. What is depression? According to the American Psychiatric Association, depression, or major depressive disorder, is common, and it's a serious medical illness that negatively affects how you feel, the way you think, and how you act. Depression causes feelings of sadness or a loss of interest in activities that you once enjoyed. It can also lead to a variety of emotional and physical problems and can decrease your ability to function at home and at work. Depression is much more common among people with dementia. Rates of depression in the community in people without dementia is about 8.6%. But rates of depression among people with other brain diseases, such as mild cognitive impairment, Alzheimer's disease, diffuse Lewy body disease, vascular dementia, and even Parkinson's disease, are in the 20 to 40% range. This may be due in part to neuronal damage, or it could be due in part to their psychological reaction to this devastating diagnosis, or the loss of independence and impairments that these diseases cause. So we really need to be on the lookout for depression. And what about COVID's pandemic impact? We have certainly seen how COVID has caused social isolation, which is a decrease in the number of social contacts, which in and of itself does not cause depression. However, when you have fewer contacts, especially with friends and people who matter to you, this can lead to feelings of loneliness. And if this loneliness goes on for a long time, one can develop mental health conditions like depression that is diagnosed by a physician. According to the CDC, there was about a 15 to 20% increase in depression since 2019. And diagnosing depression can be particularly challenging in older adults. Why? Well, some people can't or don't want to talk about emotional pain. When you ask some folks if they're depressed, despite their obvious sad mood, they're adamant and they insist that they are not depressed. The feelings are stuffed away. And some people become more irritable, or it comes out in physical complaints like aches and pains, or headaches and dizziness, or stomach complaints and nausea. Other clues include slow rehab or frequent calls or visits to the doctor. And there are several other challenges. What do you think about self-reporting among people with dementia? Not surprisingly, they may have difficulty finding words to describe their feelings, or their descriptions or their timing may not be all that accurate. Many depression and dementia symptoms also overlap, making it difficult to tell them apart. For example, people with depression may be forgetful or have trouble concentrating, but the same goes with people with dementia. Same with motivation, or not doing their usual activities, or even self-neglect. These patients may just sit around all day and do nothing. Depressed persons may not enjoy activities and so stop doing things, while people with dementia can't come up with things to do, or planning the activity or doing the activity is just too complicated. But the result is the same. They sit around and do nothing all day. And symptoms associated with medical illness or medication side effects can also muddy the water. Haven't we all seen medications or medical conditions cause fatigue or insomnia or decreased appetite? Yes, these can masquerade as depression. So we need to address these underlying factors. So how do we screen for depression in the nursing home? First is we need to screen for dementia. Can they make themselves understood? This is an item in the MDS 3.0. If they can still express their needs and make themselves understood, they have only mild to moderate dementia, and you can conduct a direct patient interview. You can do the PHQ-9 mood interview. If they are rarely understood, then we need to do the PHQ-9 OV, which is a staff informant interview based on observations. Here are some strategies to make the PHQ-9 interview more effective. Sit down at eye level with good lighting. Eliminate all distractions, so turn off the TV or the radio. Have a cue card on hand that may help the resident more easily quantify the frequency. Maybe take his or her hand to show some support during a difficult time. Speak clearly and loudly. So, what is this PHQ-9 asking for? It is asking if the resident has been bothered by certain symptoms over the last 2 weeks. So if you go down this list of symptoms, you can check off yes or no. And if the symptom is present, then you can ask about how often it bothered them. So for example, over the past 2 weeks, have you had problems having little interest or pleasure in doing things? If the answer is yes, then ask, how often do you feel this way? Then write in the number that corresponds to the frequency. Never or 1 day is coded as a 0. 2 to 6 days or several days is coded as a 1. 7 to 11 days or half or more of the days is coded as a 2. And 12 to 14 days or nearly every day is coded as a 3. You may use a cue card if it makes it easier. And after you finish asking about all 9 of these symptoms, add up the frequency score, and it should be between 0 and 27. There is also an item about the potential for resident self-harm. This should trigger you to talk to the charge nurse or physician right away. And as you well know, many of our nursing home residents have moderate to advanced dementia. About 1/3 of all long-stay nursing home residents cannot answer the PHQ-9 questions. So we need to turn to staff who know the resident best. We should be interviewing staff from all shifts and make sure that we ask them in a private location, not in the hallway and not in the common area. Go through the same symptom questions, asking about the presence and the frequency that these behaviors are observed. These are important questions that should inform or shape how you develop their care plan down the road. So you add up the PHQ-9 frequency scores, and what do we do with them? If the PHQ-9 scores are less than 5, just continue with quarterly screening. If they score between a 5 and a 9 and admit to depression or suicidal thoughts, ask the doctor to evaluate them. And if this level of symptoms causes functional impairment, maybe we should be considering medications to help them out. And of course, put together a care plan that emphasizes non-pharmacologic interventions, such as change in environment, or change in activities, or starting behavioral activation, which we will talk more about later. If they score between a 10 and a 14, the resident has moderate depression, and you should consider getting a psychiatry evaluation and add or increase antidepressants. If they have a score of greater than 15, they have severe depression, and you need to pull out all the stops. Get everyone involved. Get the psychiatrist, the primary doctor, the social work, the nurse, activities, everybody. Okay, let's look at one of our nursing home residents. His name is Eeyore. He's been looking sad a lot these days, and he isn't joining any activities. Let's do a PHQ-9 on him. This will help us understand his depressive symptoms better and guide the staff on what to tell the doctor. This is an example of using SBAR to talk to the doctor. S stands for situation. Eeyore has a PHQ-9 score of 10. B stands for background. Talk about his relevant medical history and his medications. He has a history of hypothyroidism, depression, and chronic pain. He is on Synthroid 112 micrograms a day and Zoloft 25 milligrams daily. A is for assessment. Go over the PHQ-9 items. Eeyore has been looking gradually more and more depressed in the last 3 months. However, in the past 2 weeks, he's feeling down and depressed more than half the days. He feels like a failure and feels like he's let his friends down half or more of the days. He has little interest in joining activities and has trouble concentrating for half or more of the days. And sometimes he thinks he would be better off dead. R is for recommendation. How do you think the doctor can help Eeyore? Doctor, I'm worried that he may be quite depressed. Would you like to see him soon? We can also meet with the social worker and rec therapist to review his activities care plan. Do you want to check his labs, adjust his Zoloft, or have the psychiatrist see him again? So what do we do next? Should we just wait for the meds to kick in? We may be waiting for weeks. We need to try non-pharmacologic interventions. And a really good one is called behavioral activation. In the next few slides, I will explain behavioral activation in more detail. Let's take a look at Eeyore. His tail keeps falling off, and he's very embarrassed by it. And he's fearful that it will happen at the worst possible moment, and he might get laughed at, so he doesn't go out. He avoids activities, and this leads to more isolation and feelings of loneliness. And the longer he stays in his gloomy place, the more depressed he gets. And the problem here is that this makes him even more afraid to go out. So he continues to avoid activities, even when he's invited, which makes him even more lonely and depressed. And on goes the cycle of negative reinforcement. So what is behavioral activation? It is a cornerstone for the psychological treatment of depression. It is a type of cognitive behavioral therapy that breaks the cycle of negative reinforcement. It is a switch to positive reinforcement. It is an outside-in approach that starts with planning pleasant activities that boost mood. And it works for everyone, whether or not they have dementia, or even if they have moderate or advanced dementia. So let's take a look. Here's Tigger, his good friend. He says, I have a great idea to cheer Eeyore up. So Pooh responds, great, let's plan for it on Saturday afternoon. So what are the steps to behavioral activation? Well, the first step is to plan. Ask the family and friends about pleasurable activities, and make sure these are things that the resident likes to do. Don't take Eeyore bouncing just because Tigger likes bouncing and wants to do it with him. Take him to the thistle patch for a picnic, even if you don't like thistles, or find something else that you like to do together. The activity needs to be individualized or person-centered. Step 2, schedule. We need to be scheduling a daily pleasant activity. We need to include details such as the day and the time, for how long, and with whom. And it's important to identify any barriers so we can find ways to overcome them. We need to make the plan feasible and realistic. Step 3 is to evaluate. Well, is this plan having any impact, right? So let's take a look. Is he spending less time sleeping? Or is he having less negative verbal communication? Is he moaning less? Are we observing other behaviors? How is his appetite? Is it getting better? And step 4 is to improve. So if it's not working quite as well as you were hoping, then maybe switch, substitute, or make the activity easier to do. Revise the plan based on how they are responding to each activity. Adaptations are really helpful. Okay, I'd like to introduce you to the GRAPES tool for behavioral activation. GRAPES is an acronym that gives us ideas for activities in a mix of categories. Let's take a look at some examples. G stands for gentle. Gentle activities. Be gentle to yourself. R for relaxation. Make time to relax, such as a spa-like environment, gentle massage, or watching fish. Accomplishment. Accomplish just one thing. That maybe just fold laundry or write that letter that you've been meaning to do. P is for pleasure. Listen to good music, taste a sweet fruit, pet an animal. E is for exercise. Take a walk, stretch, or move around. And S is for socialize. Spend time with others. And then make a daily plan. Fill it up. Fill up your calendar with different GRAPES items. According to the Positive Experience Program at Stanford University, the goal is 4 pleasant activities per day to keep the blues away. But I know I have a few cynics out there, and I bet you're thinking, but I've tried that, and every time I suggest an activity, he always says no. Well, you're right. It's entirely predictable. In fact, isn't that the hallmark of depression? They don't feel like doing any activities. That's okay. They don't need to feel like it. They just try the activity and trust that the feelings will follow. That's why it's an outside-in approach. So negotiate. Start with less. Start low and go slow. Meet them where they are. Ask about their reasons and start with the smallest version of the goal. Ask, what are you willing to do? And then experiment. Instead of walking for 20 minutes, can we try walking for 5 minutes? Or walking 15 feet? Or even just doing sit to stand, right? Keep going small. And here is another strategy called tiny habits. This was developed by a Stanford behavioral scientist, B.J. Fogg. And this is how it goes. First, you take any new habit that you want and you scale it back so it's super tiny. Then you find where it fits in naturally in your existing routine and ask yourself, what does this habit come after? And then in addition to making this super tiny and using a routine to remind you of it, you hack your brain by calling up a positive emotion, by celebrating, whether it's fist pumps, raising your arms, high five, or doing a happy dance. Whatever it is that helps you feel successful, that is what will help wire in the habits. And so this tiny habits thing is ABC. A is for anchor, B is for behavior, and C is for celebration. As you can imagine, depression can be like a big boulder, a big rock that is hard to push over the hill, and it needs a lot of help. So here is you, right over there, right, trying to pull this rock up the hill with behavioral activation. Behavioral activation is so important because it is actually the medicine that will ultimately overcome and prevent depression in the long haul. But the rock is too heavy, so you need help. Sometimes antidepressants can help start behavioral activation start to happen. And so sometimes a psychologist or a social worker can also provide extra support and encouragement for your efforts. And don't forget to include friends and family as well to do some cheerleading and to be part of the team. And so this leads us into a discussion about medications for depression. There are many classes of antidepressants. I like to visualize this as different flavors of ice cream, and the choice depends on patient characteristics and the side effect profile of different antidepressants. For example, if you have a depressed resident who has trouble sleeping at night, the doctor might choose trazodone. If your resident has trouble with poor appetite and insomnia, you might choose mirtazapine. If your resident has pain that keeps them up at night, maybe duloxetine or desipramine might be better. If your resident is too tired to do anything and needs something more activating, maybe try citalopram. Or if the resident has a lot of anxiety that goes along with the depression, you might consider citalopram or bupropion. So it all depends, and your descriptions of the behaviors will help the doctor decide which one to try first. But you should also know that antidepressants take a long time to work. It may take a good 4 to 6 weeks to see a good response. So you should consider increasing or switching the dose to another antidepressant class if you do not see a response in 3 weeks. But the most important thing is don't give up. And here's another thing to be aware of. All medications have side effects and drug interactions, and they need to be monitored closely. If you see any of these side effects, sleepy, confused, more depressed, anxious, agitated, restless, or dizzy, you need to let the doctor know right away. But your main approach should be non-pharmacologic care. So you've tried increasing the trazodone, and you began behavioral activation activities. So in 3 months or so, you can do the PHQ-9 again to see if there is any improvement. It will be great to show that your efforts are paying off. And this slide is to remind you that this is a team effort. There are many factors that contribute and drive depression. It could be their medical problems, so you got to get the doctor to help improve the medical status. Maybe you need to maximize sensory and functional status, or maximize exercise and nutrition, or address family issues, right? So we need to pull everyone in to help. It'll make the rock more easy to move. So in conclusion, here are the main takeaways. Depression is a serious medical illness that has a big impact on the person's quality of life. Depression and dementia often occur together, and they should be screened and evaluated for both. Non-drug approaches should be tried first, and behavioral activation is something that caregivers, families, and friends can do together. Antidepressant medications can help patients with depression, and it is important to have a comprehensive approach. Use the entire team. Thank you for caring.